All right. So I'm going to give two talks in this course, the second one being tomorrow on abdominal organ transplant. Today we're going to be talking about living donor evaluations. This is how donor candidates end up being evaluated to see if they're going to be good donors. So the purpose of this talk is for kidney and liver transplants and their potential donors. We're going to review transplant types and configurations briefly, the preoperative assessment of potential living donors with attention to how we help surgeons and subsequently the fact that this is a great opportunity to help the donors and the recipients themselves. We're going to talk about parenchymal evaluation of the ins and outs, which are largely vascular, but there are some other things going on. We're going to talk about the identification of important variants and surgical constraints, and then we're going to focus just a little bit on some imaging techniques and with a description of kind of how we do things at UC for kidney and liver transplants. So first off, just some general concepts here. There's an increasing demand and supply mismatch, and that's why we're seeing an increasing number of living donors, which is why these topics are relevant. Transplantation strategies, importantly, try to approximate the normal physiologic environments for the transplanted organ or organ portion. These strategies try to avoid or minimize negative impact to the donor remnant organ function and maximize the likelihood of normal graft function in the recipient. And then, of course, we're looking to make an evaluation and provide information that prevents or minimizes surgical complications. All right, so the donor candidate evaluation really is kind of this tripartite thing. Of course, there's a medical evaluation, right? Patient history, blood type, labs, cancer and infectious disease screening, et cetera, right? And then there's a psychosocial component of this, mental health, what kind of support systems, illicit substance uses, alcohol and tobacco use, other things like that, things that really kind of dictate how well this might go in terms of an ongoing patient management strategy. But really the large one here that we're going to talk about is the radiological evaluation. And that's, of course, again, evaluation of the parenchyma, its structural relationships to other things in the abdomen, vascular anatomy, and the anatomic variants. All right, so let's start off with the kidney here. There's really one in and two outs. It's, of course, the arterial supply and the venous drainage and the collecting system / ureter. So transplant configurations are numerous, and I'm just going to highlight just a couple kind of key features of the most common arrangement here, which would be a right iliac fossa implantation with end-to-side anastomoses of the donor renal artery to the recipient external iliac artery and the donor renal vein to the recipient external iliac vein. And then, of course, the donor ureter is anastomosed to the bladder dome of the recipient. There are many, many variations, some of the most common being a pseudocorel patch. This is where you use a segment of vein harvested from the donor and to make essentially one anastomosis out of many. So they can prepare this Corel patch or pseudocorel patch on the back table prior to warm ischemic time. This is useful for living donors, particularly those with multiple arteries. Every now and again, the donor renal artery will be anastomosed to the internal iliac artery in an end-to-end anastomosis. Sometimes there's a pylorureterostomy. This is where the donor renal pelvis is anastomosed to the recipient ureter. And then sometimes they place these things in the left renal fossa due to some anatomic constraints. All right, so let's talk about the living donor radiologic evaluation of the kidney. So first up is parenchyma, solitary kidney, classically and clearly a no-go, so not a renal donor. Horseshoe kidney, also a no-go. This just presents too many surgical complications. Renal ectopia. So ectopic kidneys can be used pending, evaluation of the other things that we're going to talk about shortly. Kidney size is important. So kidney size gives a kind of estimation of how much nephron volume there actually is and how useful the kidney will be in a donor and implantation setting. You want to measure the renal length in using a double oblique MPR method as kind of shown here, and that is the most accurate way of measuring the renal length. You could use renal volumes, but basically in most healthy kind of patients without a renal history, the length would be a good surrogate. Parenchymal lesions. So cysts and masses, as long as it's a characteristically benign mass, like an angiomyolipoma or something you can say with some kind of certainty, these don't present any real problem, so long as they're not absolutely huge and presenting some kind of surgical complication. Small RCCs, this is controversial. Looking through the literature, particularly in other countries, but also in some centers in the US, sometimes these very small lesions will be enucleated and the kidney will be used because there's really a low risk of recurrence and metastasis for very small renal cell carcinomas. Calcinosis and scarring, this is kind of on a case-by-case basis. Nephrocalcinosis is usually a no-go because there's some kind of underlying metabolic disturbance here, which is going to predispose the donor to a future problem in their solitary remnant kidney, right? And then scarring is usually acceptable if it's not severe and the functional nephron volume is reasonable. Perinephric fat volume is something you want to pay attention to on these scans because most of these kidneys are harvested laparoscopically. And of course, when it's a laparoscopic procedure, right, a large rind of perinephric fat presents a kind of a challenging surgical scenario for the surgeons. All right, so let's quickly talk about arterial supply. There are kind of three main types of arteries you want to pay attention to here. There's the capsular artery, which usually branches around the upper or lower pole. It doesn't make a very clear and direct, obvious communication with the kidney, but it throws off small radicals, which of course perfuse the capsule, hence the name. There's, of course, the hilar artery or the main renal artery, which gives off its segmental branches, some of which are segmental and enter the renal sinus, and some of which dive directly into the parenchyma as polar arteries at the upper or lower portion of the kidney. We want to make note of the number of renal arteries. You can see here in this case, we've got kind of a dominant upper pole renal artery and then this lower one, which branches into two segmental arteries. Multiple arteries presents a surgical challenge. Again, if you're trying to make multiple anastomoses during warm ischemic time, this will lead to delayed graft function and other kind of outcomes challenges. You may need a pseudocorel patch from a vein segment or multiple anastomoses. Small upper polar arteries can be sacrificed, and by small, I mean usually less than 2 millimeters is what is acceptable to surgeons, because this will result in what they call an acceptable infarct volume here at the upper pole. It's usually 5 to 10, maybe even 15% of the graft itself. But lower polar renal arteries, even when small, this should be kind of an exclusion here because those things tend to perfuse the renal pelvis and the proximal ureter. And so sacrificing that vessel or having a complication related to an anastomosis of such a small vessel can lead to renal pelvic or ureteral necrosis and then attendant outcomes challenges. So here's an example of an accessory upper polar renal artery, and what you can see is it dives straight into the parenchyma here. There's no fat surrounding it. It just goes straight into the parenchyma. All right, you want to make note of the origin, the course, and the caliber of the vessels. And here's an example of bilateral inferior polar arteries arising from the left renal artery. These things may arise from all kinds of different nearby vessels in the abdomen. And here in green are just some of the variations that I've seen in my practice: iliac arteries coming off the celiac trunk, gonadal artery, and the middle sacral artery, for instance. Atherosclerosis. So the reason why you want to make note of atherosclerosis in the renal arteries, aside from its importance to the donor, is that atherosclerosis predisposes to injury during cross-clamping and post-transplant stenosis and thrombosis after implantation. So you want to make note of that. Sometimes a limited endarterectomy can be made if appropriate, but the surgeon should be aware. Fibromuscular dysplasia is not terribly uncommon in the renal arteries, and it's got this classic beaded appearance here in this medial fibroplasia type of case here. It's not an absolute contraindication, contrary to most people think, and if a very limited segment of the vessel is involved, it can sometimes be resected and the kidney still used, but our surgeons do want to know about this. Now, there are several different kind of important measurements here regarding to the branching patterns of the arteries and the confluence patterns of the veins, which we're going to discuss and which will be shown in these figures here off to the screen right here. And what is important is that remembering that this is harvested laparoscopically. So we're talking about working behind major vessels in a laparoscopic sense is very challenging and can be quite dangerous. So first off, we want to measure the right renal artery ostium to its first segmental branch. This gives a measure of the absolute longest renal vascular pedicle that can be used for the transplant. And then more importantly, in the laparoscopic sense, is the first right renal artery segmental bifurcation to the rightward margin of the inferior vena cava. That's measurement B here. And again, that's because it's very challenging to work behind the vena cava in a laparoscopic setting. Similarly, measurement C here is the left renal artery ostium to the first segmental branch. Again, the measurement of the vascular pedicle for implantation. Key distances to remember correspond to what we call early branching, and this is the right renal artery segmental branching behind the IVC or within 1 to 1.5 centimeters of its rightward margin. So you want to have an idea of what your safety margin is here for vessel ligation. The left renal artery segmental branching within 1.5 to 2 centimeters of the aorta is considered a very short vascular pedicle and can pose its own challenges. Also, you want to make note of the origins and locations of the inferior phrenic and the adrenal arteries, which very commonly